and a warm welcome to this edition of the Philips African Dialogues. I'm Kukuletu Cele. Now today we will be taking a look at access to healthcare, not only in the country but across the continent as well. The different types of innovations that need to be implemented, the potential government incentives and policies that need to be changed, and also what the private sector can do by rolling out capital and investing in a worthy cause, being access to healthcare. Well, today we also set at the backdrop of the Diepsloot Methodist Church, where a mobile clinic has been launched together with Philips and the Reza Project Group. But to help us tackle this heavy topic with regard to healthcare, I'm joined by my esteemed guests of panelists today. To my left is Jose Fernandez, the General Manager for Philips Southern Africa Healthcare, Bennett Asia, Director for Districts and Development at the National Department of Health, Saul Cornick, the Chief Executive of African Health Placements, and Dr. Michael Moore, founding member of multinational company Hello Doctor. We're also joined by our esteemed group of audience members who, a few of them will be participating in the discussion and maybe sharing some of their insights as well. Well, let's get into this particular topic. It's a heavy one, one with a capital interest, but more importantly, a personal interest as well for all of you. But I'd like to start with you, Jose, by getting your feel and perspective of the current landscape when it comes to health access, not only in South Africa, but across the continent too.
Well, thank you very much. Actually, there's so much going on at the moment. If you look at Africa in general, you know, on the one hand, you see this economic prosperity over the last 10 years, and you see the middle class rising. You see all kinds of expectations. You see the development of mega cities. Now that brings with it a whole requirement in terms of healthcare, and it's really, the growth is outpacing what healthcare can do. Having said that, you still have in sub-Saharan Africa only 32% urbanization, so you have a huge rural healthcare, population as well, which needs attention. And we know that in this area there's obviously quite a strong need to do or come up with solutions to improve that as well. So we see this dichotomy. We also see that essentially the non-communicable diseases are really growing. You know, so with this prosperity comes your lifestyle diseases, and we see this growing. The infectious diseases aren't all going away. Yes, a lot of progress has been made, but they're not all going away. So actually the burden is becoming bigger and bigger, the resources fewer, and I think there's a lot that needs to be done.
So I'd like to come to you, because this is clearly where you found an opportunity as well, but someone who comes from financial industry, observing into the medical space in South Africa and across the continent, your view on the landscape at the moment.
Yeah, it's quite an interesting perspective to come into the healthcare sector with. I'm not a doctor. I didn't have a healthcare background before I got involved in starting Africa Health Placements. What I see varies depending. It's difficult to say this is the state of healthcare in the continent as a whole. It differs. Particularly South Africa is quite different in its landscape to other countries. The one thing you can say though is that ubiquitously across the continent there's a shortage of skills. I think we have 25% of the global population, over 30% of the global disease burden, but only 2% of the world's physicians. So we're short of skills whichever way you look at it. People sometimes say, well, South Africa is better off than most because we have on average 69 doctors for every 100,000 people. Whether we're a country like Malawi, we'll maybe have 2 or 3 doctors for every 100,000 people. But the reality in South Africa is that 75% of our doctors work in the private sector, serving 20% of the population, which means that only 25% of our doctors are serving the other 80% of the population. And the vast majority of those doctors are working in urban centers. That means that 43% of South Africa's rural population, or 43% of the population rather that is rural, has access to the same number of doctors per population as the worst off African country. So just to make the point that it differs in South Africa, and it differs. South Africa differs to the continent, but in many ways, it looks very similar in terms of a shortage of skills. I mean, we can come to this maybe a bit later, but I think a lot of the problem there is the fact that we have such a doctor-centric system that we seem to be short of skills. And I think there's this idea of leapfrogging, for example, in Africa, where we've managed to avoid having to put down landline networks for telecommunications and have been able to leapfrog straight into mobile technology that has created a huge amount of value for the continent. I think in the same way, if we're able to look at primary healthcare issues and what needs to be addressed there, we can perhaps leapfrog this need to have a doctor-centric, hospital-centric system that requires a huge amount of training and a massive investment.
Bennett, to come to you, speaking from government's perspective, I'm sure you'd agree that we have made progress, but we're still a long way off.
Yes, I think that's correct. However, I think what we need to just keep in mind is that whilst we try and improve service delivery, improve health outcomes, we're also busy with major transformation within the health sector. Given where we come from in terms of having had a system which was population-based or race-based, so therefore we need to make sure that all the issues that we need to deal with from a difference in how we perceive health issues, how healthcare should be delivered, we need to bring that into the equation. It is also quite evident that we have made major strides in terms of improving health outcomes. If we look at the life expectancy of males and females versus what we had, then that's evident to, in part, the improved health care that we are currently delivering. I think there are a number of policies that we have introduced, but at the same time those need to be costed. We're also quite fortunate in this country that we, strictly speaking, do not have a scarcity of resources, financial resources as well. It is how we harness the available resources with the needs. I'm not saying we have enough money, but in terms of how we use the resources to deal with the issues, that should see us through. We're also not largely dependent on donor support. And if we bring that into the equation, that we should actually achieve much more with the resources that we have. There's also the allegation in the World Health Report that was released recently that if we compare with other countries, middle-income countries like South Africa, Brazil, etc., we're actually much worse off in terms of the health outcomes versus the resources that we put in. And poorer countries are sometimes performing better than us, given the resources that we put in for service delivery. So I think there needs to be a major shift in focus in terms of using the available resources to make sure that we match the desired health outcomes.
I'd like us to zone into that particular aspect of resources that you've alluded to. And Michael, maybe if we can get your voice into the conversation with regard to these resources. Significant lack, and maybe that's again where the private sector gets to play more of a pivotal role, taking the lead on that front.
I think much has been said already from the existing panelists. I think to bring mobile health into perspective, if you look at a population segment of 10,000 South Africans, we have 116 odd community health workers that can service them, around 16 nurses, 2 doctors, and a specialist. But we have 10,000 mobile phones. I mean, the penetration and the saturation of mobile phones in this country and in Africa is essentially 98%. So I've always said, and I say this somewhat controversially, but there are 2 things every African has, tuberculosis and a mobile phone. And if we can use that mobile phone to reduce costs, to extend reach of our limited resources, we can leapfrog, to Saul's point, the crisis that we're in, the inadequacies and the big divide between private and public healthcare. And I think it's how we make use of those mobile services, how we take current technology that is available to every African and make the most of that as far as healthcare is concerned. So it's maybe less of getting extra funding in, as Bennett said, and more about reducing costs by being clever with how we utilize technology.
Is that taking place? And maybe you can tell us from the private sector's perspective. Obviously, you've got the innovation regarding apps and mobile apps that you've delivered in the hands of consumers to create that awareness of their health and the environment around them.
It is taking place. I mean, this is not a platform for a sales presentation, but what we see the World Health Organization saying around telemedicine and teleservices is that on average in South Africa it costs a patient, or costs the government, 250 Rand per patient visit to a hospital. Very expensive place to treat an individual. Whereas if you can treat them telephonically or mobily, there is cost savings for the patient. There's no need to travel. There's no need to get to a clinic on the wrong day and be referred to come back on Thursday afternoons for antenatal clinic, etc. There's time saving, all of that. So there's significant savings to be had just by giving rural communities in particular access to telemedicine or mobile health services. And again, the World Health Organization has listed ad nauseum the benefits of that. And I think the real challenge is a lot of countries are saying, but we're not ready for this, we don't have regulations or policies in place, How do we protect the consumers or the patients? How do we protect the doctors, etc.? So I think it's government needs to get on the front foot in terms of regulations and policies around e-health or m-health, whatever you'd like to call it, so that we can be prepared for the onslaught that's already happening around the world. And as I said, be on the front foot for what is potentially a life-saving service to so many South Africans.
Go ahead, Bennett.
If I can just come in there, Michael, we have launched and adopted the compatibility standards, which is a set of norms and standards to be used in mobile technology, how to set up this health information exchange in terms of patient data, etc. So I think whilst that is in its infancy, we already see the benefits of that. For example, about 8 months ago, we launched an mHealth application which is called Mom Connect, whereby it is the intention to register all pregnant women by cell phone onto a national register in the form of a database. Currently, we stand at about 384,000 mothers that have been registered. It is fairly cheap. One of the mechanisms to register a mother is to use her own cell phone and log into to the website. She therefore can register herself. It's non-invasive, privacy is protected, etc. So I think that is a prime example of how we already. There are others, but that's a prime example of how we're moving into that field.
Maybe if I may add to this, I think e-health is absolutely a very important aspect to health going forward. But it also touches on the broader technology. So we're not going to see sufficient health workers and doctors tomorrow in Africa. We will always have this deficit. So what do you do today to keep pace with the demands? And I think if you look at the broader technology, there's a lot that can be done. And then we look at things like using the people you do have with task shifting, for example. So I'd like to share 2 examples which are already so good. The one is in Tygerberg Hospital, where we had an obstetric critical care unit which was really overloaded because all the patients were coming through to a tertiary institution, and really the unit couldn't cope with this volume. And at that stage, we had around a 6% maternal death rate. So we sat together with Dr. Langenegger and we looked at how do we resolve this, because the skills aren't there. We don't have ICU nurses to come in and to just simply take over and grow the unit. So we did a step down unit, and we took appropriate technology, and that's the word, appropriate technology for that setting, that actually has some intelligence and decision making built into it. We took general ward nurses and we upskilled them to really know how to operate within an ICU environment, but all of a sudden we had a general ward nurse with the appropriate technology producing results. And I'm glad to say that within a few weeks, the maternal deaths were down to 0, and they've been 0 ever since. So this is an example of how you can use technology to really close those gaps that we see in terms of the expertise. The other example, a little bit more in the rural setting, this was in Uganda, and we partnered with Imaging the World, and we got health workers to go out into the real rural areas of Uganda and scan mothers, pregnant mothers. Now, they had no idea what to do with these ultrasound units, but they were taught a protocol. You do it in this shape and that shape, and then you actually just archive the video, you send it to a central point, and people will then look at it. And it was a huge success. And I think we need to be creative and pragmatic around technology and how technology can help the shortage of skills in Africa. I think it's doable.
I want to follow up on that theme of the investment in technology and all these other supportive industries, because for the technology to work, we need broadband services, which government is still taking its time on rolling out on. Before that as well, you also need the roads, and the bricks and mortar, I think, will also not necessarily lose its positioning. Maybe walk us through what we're here for today, which is the launch of this mobile clinic between yourselves as well as the Visa project. Clearly, if the healthcare service isn't in the hands of the community, you're bringing it to them.
Right. So from our perspective, we really believe that to have a strong healthcare system in any country, you have to have a strong primary healthcare system. And we work a lot in strengthening primary healthcare system around Africa. Reza Foundation, obviously, they an NGO which operate with communities and uplifting communities, and they identified the need. But the minute they spoke to us as Philips, it just resonated, because this is exactly what we look at in terms of uplifting communities and providing solutions. And we quickly started looking around technology to say, right, what would make an impact in a community like Diepsloot, and what would we put in there? And of course, then the focus of dental and maternal and maternal health and mother health came to the fore. We put in there ultrasounds, which is really an innovative ultrasound. It's kind of a handheld tablet device which is specifically designed for remote settings. So we're quite excited. This is actually the first time we deploy it in South Africa. But then we look at things like obviously your colposcopes for your routine examinations to pick up cancers of the cervix. And we're looking also at CTG, so fetal monitors, just to monitor the pregnancy. So this is I think will make a huge difference in a community like this. You can roll out a service, see how it develops, and you can easily follow that up with a bricks and mortar, as you were saying, because you create a service which can then grow and evolve into a bricks and mortar service, which we also do in the form of a community life center. So,
I'd like to cross to the floor now. We've got Mr. Nick Henry. He joins us from the Reza project to give us slightly more perspective as well. Partnership with Philips and the launch of this. First, I understand, in the town of Diepsloot, and there are several expectations that you have here, no doubt. But maybe if you could give us more perspective on the kind of capacity that this facility has, and if it succeeds here, where else it could potentially be rolled out to.
Obviously, with this being a pilot project, there are certain kinks that need to be ironed out in the first 2 or 3 weeks of it running. And in terms of getting it to a place where we're happy that everything works as it should, there has been huge interest shown by other possible sponsors and partners, and we are looking at really rolling this out possibly in other townships where there is a need in Johannesburg. So there is huge potential for rollout of more new units in the future.
And I take it if it succeeds here, then the rest of the world and the continent
it's
is
the
indeed your oyster. I want us to focus on skills as well, because with the technology as well as the service being available, but none of this will happen unless we have actual health workers who are on the ground making use of these services and hopefully implementing some kind of change in the lives of the patients that they come across. I'd like to come to you, Saul. On the 12th of May was International Nurses Day, which also correlates with Florence Nightingale's birthday, believe it or not. And reading up on some research, it does seem as though a lot of nurses feel underappreciated, as though their services are often neglected, and the interactions that they have with patients, especially in rural and even township areas, are not of a positive nature. From your perspective, does it go back to maybe changing the mindset of these healthcare workers who actually have to work in such difficult environments?
That's a very good point, Gugu. We talk about healthcare, but we often forget that care forms part of that word. You can have all the mobile services you want in the world, but unless you've got people there, the healthcare doesn't actually happen. We've run surveys, the kind of standard corporate retention survey that any company around the world would use to understand what the employee value proposition is to its employees. We've run surveys like that in the hospitals and the clinics we support. And it's been quite interesting what we find. We find that by far the strong element of the employee value proposition for a nurse is the sense of purpose that that nurse has in the work that he or she is doing. And that shouldn't really surprise one, thinking they've gone into healthcare in the first place. And it also means that in terms of creating a good working environment, at least you're not trying to find a sense of purpose in a manufacturer of firearms. You're trying to create a sense of purpose in a health environment is a lot easier. But the thing that's the weakest is the work environment, the culture, and the management that nurses experience in facilities. And for those reasons, the employee value proposition becomes weak, and nurses want to leave or they don't feel satisfied in their jobs. And it does come back to mindset. But mindset and values and purpose are things that live inside one. They aren't things that one can see. What really needs to happen is that we need to be clearer with our health workers about what that looks like in terms of visible and measurable behavior, and making sure that we articulate those behaviors and embed how those behaviors are lived out in every interaction in the systems that are set up in mobile clinics through mobile methods of providing healthcare and in the way we're managing our health system. And I think that's something really important that we've seen, just to emphasize the articulation of those behaviors and making sure those behaviors are reinforced in the way the work is done in the environment.
Can I add to that, Gugu? From a personal perspective, there's nothing more wonderful than being able to serve a patient completely. And I think some of the frustration that our nurses and our rural doctors in particular will experience is an inability to serve their patient completely because of a lack of certain resources or a lack of support. And from our perspective, in terms of giving nurses, for example, access to mobile health, direct access to doctors, to specialists for advice on the spot, really aids in that ability to give proper care, proper support to the patients in front of them. So I think that's key, just closing the loop of support for primary healthcare workers.
We need the support, and Bennett, you can come in here as well with regard to the rate of skills development. Are we lacking in maybe just pumping out as many people into the system without having those core values, as Saul alluded to, and understanding of the support system that Michael mentions as key critical elements of their job?
Let me come in with a different angle. I always maintain that when people say the health system collapsed, primary healthcare services collapsed, this hospital collapsed, who made it collapse? The hospital can't collapse on its own. We are the health system. Those of us working in a facility, the doctor in his surgery, the doctor in the operating theatre, even that nurse managing the patient using mobile technology, she, or he for that matter, makes the health system to work or not, because it is the experience of the client that counts, not how well the facility is being managed or being run. And that's why we many a time have complaints being raised or issues being raised about bad attitude of nurses or health workers that are rude, etc. But we also forget that those are human beings. And somebody needs to look after them in order for them to do their job better. Some of the issues that have been raised in terms of poor working environment, not having the necessary skills. If you're a mechanic and you work for a garage or a workshop, etc., who is supposed to provide those tools? All right? Because you're not self-employed. So are we expecting nurses to bring their own bomonometer if there's not a bomonometer in the clinic? Clearly not. But I think how, again, we strike a balance between what we expect healthcare workers to do versus the demands that come from service delivery. Coming closer to skills development, we are spending billions of rands on skills development programs of various degrees and nature. Undergraduate, postgraduate, in-service training, on-the-job training, etc., etc. I think what we need to do is to make sure that people adopt those skills in order to do their job better. And it's not just, oh, I've now been trained to do immunization, call all the babies that need immunization, stand in a queue, and give all of them a jab. So it's also the passion that needs to go with those. And I must admit, in many an instance, those kind of things are lacking. And we need to make healthcare workers understand that they're there to serve the client and not the other way around. And that's why we also adopt a policy to have more outreach programs to communities through a policy arrangement which we call the re-engineering of primary health care, whereby we set up word-based outreach teams, setting up district clinic specialist teams, whereby, for example, you have, given that those are scarce skills in terms of pediatricians, obstetrics, gynecologists, etc., send them out to a central point where the community doesn't need, or a client within the community doesn't need to travel 200 kilometers to the nearest referral hospital, but take those services there. And the reason why I'm bringing that in is also, part of that is also the reorientation in terms of service delivery. Because now you're not just in a hospital setting, you deal with providing services to a community. The community health workers who are part of a ward-based outreach team, they are being reoriented in terms of how to deal with a household arrangement, mother, father, children, granny, etc. But also the additional skills that go with that, to say that when you go to a household, it's not just to check whether the child is immunized, whether the granny took chronic medication for diabetes, etc. But it's also if the granny, for example, doesn't have an ID book, it's that additional set of skills and the caring part that comes in to say, I know where to refer you to, or you should get your ID book because you qualify for a pension, etc. So it's also the broadening of the understanding of the needs of a client, whether it's in a household, a community, a clinic, or a hospital, and not just the way the client presents with that particular disease at that point in time.
So broad and multi-skilled services, obviously. So I want to get your voice in here again, because you get a lot of international healthcare workers to come and work in tough environments across the continent, which are not easy, judging by the videos on your website. I want us to walk through that, because it almost seems as though there needs to be some kind of skills transference, as you allude to, a benefit, and more importantly, an incentive. Or should we even be looking at incentives, because these healthcare workers need to balance the need for, as you mentioned, Michael, helping to assist a patient full circle, but also financially there need to be some kind of benefits that they reap too.
Yeah, absolutely. So just to put it in perspective where I'm coming from, we've placed over 2,500 foreign qualified health workers in Southern Africa since 2005. We've also placed about 1,200, 1,300 local qualified health workers. So we've seen both sides of that. The perspective we come into the foreign qualified health worker recruitment space with is the following. The US, 30% of the US health workforce is foreign qualified. 30% of the National Health Service in the UK, the second biggest employer on earth, is foreign qualified. These are some of the wealthiest countries in the world who can afford to train a lot of health workers, and yet they're relying on foreign skills. If the richest countries in the world are relying on foreign skills, should we not, as South Africa or as the continent, be looking at it in the same way? So with that perspective, we went to take a look and see what are our competitive advantages over countries like Australia, Canada, the US, Europe, in terms of attracting these globally scarce and globally mobile skills. And what we found over the time that we've been working is the following, that we've got three big competitive advantages. And funnily enough, the finances obviously isn't the attracting factor on the continent as a whole. But certainly we can offer better work experience than you can get back at home. So we say to these doctors, come deal with infectious diseases rather than dealing with colds and flu in Wiltshire. We say there's a humanitarian appeal. You became a nurse for a reason. You can better exercise that here than you can dealing with the cases you're dealing with in a very wealthy context. And then there's of course the lifestyle piece which Africa can offer. So with those competitive advantages, we've found that we've been able to attract thousands and thousands of health workers to come and work on the continent. The problem to getting them in has not been what we can offer. The problem to getting them in has actually been the barriers that we've put up that stop them from coming in bureaucratically.
Like the visa regulations.
Visa regulations is one, but there's certainly a lot that can be done to the visa regulations is a South Africa specific thing.
Yes.
And there are actually visa regulation issues across many countries in the African continent. So this is not particular to South Africa. But what we need to do is we need to look at how we can make it as easy for a doctor to get into Africa as that doctor can get into Australia. If a doctor wants to go work in Australia, the doctor goes online, fills out some forms, submits their application. 3 months later, they know they've got a yes or no answer, they've got a job, and off they go. The process here is a lot more unpredictable, a lot more expensive, and a lot more opaque. The last point just on salaries, South Africa is in a very, very advantageous position since the OSD. The OSD was a boon to health workers in South Africa. The OSD is occupational specific dispensation, whereby the grading and the pay levels for various cadres of health workers in South Africa were reassessed, and they were paid what they were considered to be closer to market value. As a result, South Africa, based on a study we've just done where we take a look at cost of living, South Africa, once you take into account cost of living, pays its doctors one of the highest in the world. yes, it may not be the same in dollar terms, but in cost of living terms, it's one of the highest in the world.
Is that the public sector?
That's public sector in South Africa. The government pays fantastic salaries. And when you take into account the benefits that health workers in the government sector get, it is even better than the private sector. We're actually working with a number of low-cost private sector providers who are struggling to recruit health workers out of the government system because they simply can't match that remuneration that's being offered. So the issue of remuneration in South Africa is not on the table. There are other issues around the retention and the barriers to allowing health workers in the system that need to be looked at, not remuneration. Other African countries, certainly.
I'll tell you what, we'll take a quick short ad break and come back with this conversation where we take a look at healthcare access as well as the innovations behind this here at this Philips African Dialogues debate, where we're coming to you from Diepsloot. Welcome back to this edition of the Philips African Dialogues discussion, where we're talking healthcare and access to healthcare. And just before the ad break, Saul, you touched on the fact that Africa as a whole has a very unique selling point when it comes to attracting foreign talent to come and work on the continent. Michael, you wanted to give us more perspective on innovation and how they can, maybe some of these healthcare workers who come into this part of the continent actually think differently and can innovate things differently for the future of healthcare overall?
Sure. I just want to laud the government for its sort of intention to not wait for patients to come into clinics and hospitals, but actually to go out to the community and serve the community, which is wonderful, and I think we're making great strides as far as that's concerned. But what about, and this is just some alternative thinking, what if we prevented the community from coming to clinics and coming to hospitals? And by that, and it depends what you read, we're looking at statistics of around 40 to 50% of people that come into clinics or hospitals don't actually need to see a healthcare worker. What if we could capture that group of individuals and get hold of them first, almost screen them out using mHealth technology or giving them access to a doctor over the phone? That would save the government incredible amounts of funds in terms of the cost of treating a patient. And we've seen, from Hello Doctor's perspective, giving consumers access to a doctor using basic technology, so they don't need data, they don't need smartphones, using feature phones, using USSD, they're able to access a doctor. We make the call to the consumer, and we've found that 6 or 7 out of 10 calls are actually resolved over the phone, just by giving reassurance and advice and listening and assisting. And that's saving 60% of potential hospital visits. And those that are referred, that need to be referred, are then referred with great advice and told when and where, and it's an appropriate referral, which again aids the patient, aids the consumer, and aids the clinics in terms of their assistance.
I think that's a great idea. Within our context of taking services to communities and households, that's part of them. What we are currently doing is dealing with the ethics and the ethical issues that accompany those. I think to a large extent we also need to break down a barrier within the South African thinking that I physically need to go to a health facility to see a doctor. All right? That's why you still have a situation whereby, as much as we promote the use of the closest primary healthcare facility or any other facility nearest to where people live and work, people would still bypass the clinic on their doorstep and go to the hospital. And that's another level of thinking that we need to break down, because the clinic can effectively deal with those cases. I think Michael referred to the cost of healthcare given the different levels of care. We've done a study a couple of years ago whereby to treat a simple condition like flu at a clinic, it's something like 59 Rand per patient. If that same patient or person would go to a district hospital, it jumps to 300 Rand. Now that's also the kind of message that we need to get across to communities. And I think through programs like these, which is part of building the capacity of the community to understand what healthcare is all about, how they can save, because if they can make use of these applications in loco, in their own household, it saves them time, money, effort, staying from work, all of those kind of things, instead of going to the nearest facility. But it's those kind of barriers, I think, that we also need to break down at the same time that we try and institutionalize, implement these kind of technologies.
And I take it the cost-benefit decreases as well, Jose, where in a situation
Of
like
course.
this, the mobile clinic,
Yes.
the facility goes to the patient, thereby minimizing on the margins.
Absolutely, and I think this idea can be taken a step further because firstly, it's good if you can prevent people coming to a hospital because hospitals are generally overburdened, but can you also minimize their stay and can they leave the hospital earlier and be monitored at home? And so if you look at the complete continuum of care, Philips is looking actually from a preventive perspective, healthy lifestyle perspective, all the way through to treatment, and then how soon can you go home, because you can use technology again to monitor a patient at home. And so this then alleviates the institutions and provides space for patients that actually are critically ill and need acute care. So I think this is a very valid discussion, but I think it we will see going forward that technology will start aiding this more and more, and you'll start seeing a lot more products, both from a preventative perspective as well as from a monitoring perspective when you leave the hospital.
I want us to venture into that, the monitoring, especially because across the continent overall, you're dealing with urbanization, which is taking place at quite a rapid rate, but still very rural areas across the continent. How do we potentially bridge that divide? Jose, if I can start with you. Michael, you did allude to smart apps that are available as well as for feature phones, the USSD codes, but in a situation like this, it's a heavy burden for the state and private sector facilities to deal with.
Absolutely, and I think I've seen it too often. If you go out and you travel around Africa, you will see that you have the wrong technology being used in the wrong setting. And this is what needs to change, because ultimately, what you use in a tertiary hospital is not what you're going to use in a primary clinic. And you see today, and certainly Philips has invested hugely in this, you have to create technology that is relevant to the setting and to the environment and to the level of care. Now, recently we opened an innovation hub in Nairobi, and we are looking at creating products for Africa. One of the things that a simple example that we've actually launched in collaboration with the NGO PET is a wind-up fetal Doppler. So you simply wind it up, it builds up energy, and you go into a rural area, you don't need electricity, and you can go and monitor a pregnancy. These are the kind of pragmatic and innovative products that one needs to consider to be effective in the rural landscape. At the same time, we're also not saying that Africa does not need the high-tech. Of course they do. In a tertiary hospital, we have to give the high-tech equipment. But that divide and that split of rolling out appropriate technology at the appropriate setting is hugely important, also from an affordability perspective. Otherwise, you can't roll out enough because it's just too expensive. And I think we see a whole range of value products being developed to address this primary healthcare in this rural and remote area of health where it's needed most.
Michael, if you could come in there just to add your voice to the conversation, especially with regard to continued innovation and development, and maybe Bennett, you can also come through here, bridging that gap. I love the comment that you made about the referrals, because clearly that's where this potentially could come into play.
Yeah, and you talked about public-private collaborations,
yes.
Also in Nairobi, also in Kenya. So we've partnered with a bank that specializes in micro loans and micro savings, CBA, and the local mobile network, Safaricom. And we've literally come up with a product that gives consumers, Kenyans, access to micro loans to pay for health services. CBA discovered that 40% of their loans were for health incidents, and so what we've done is combined a health loan facility together with a health savings plan and full access to doctors 24/7, together with a little bit of a hospital benefit plan in case there is a hospitalization, all managed digitally via mobile phone. It's paperless, it's instant. And we've had phenomenal success with that. So it's being clever with technology. It's using existing infrastructure, because that's often the big barrier to entry is we don't have the infrastructure in Africa. We don't have the networks required. And what we're saying is no, we're using existing networks. We're using an existing technology platform that everybody understands in Kenya. And they can use M-Pesa to pay for services. I mean, it's ubiquitous, it's seamless, and to your point, using technology that people understand and going to where they are and servicing them with their doctors. This is not Canadian doctors or South African doctors serving Kenyans. This is Kenyan doctors serving Kenya, and for that reason, it's been a great success.
I think I can also just allude to another example of how we use ML technology at the lowest possible level. we've got a great gap in terms of not having enough data about what is going on in households, at community-based service level, etc. So these community health workers that we put into what we call word-based outreach teams is basically lay people from the community being trained, for example, to do basic things, assess the level of education, assess the level of health status, very basic, in a basic fashion, in the household, and then either give them advice or make the necessary appropriate referrals. Either for them to say, go to Google, she will assist you with this, or call Bennett and say, there's a household, this is the address, these are the people there, they need these kind of services. So in order to assist them to do that, we've developed an app using mobile phones, whereby they do the household registration, they can capture referrals, they do follow-up referrals. If there's a mother, I refer to this Mom Connect project that we've launched. In a similar fashion, if there's a pregnant mother, they can register the mother. Okay, all of the data gets submitted to the National Department, captured on site. We then use that data to say, okay, in this particular area there's a need for this. In that particular area there's perhaps an over-servicing of that particular need, okay, for a particular service. So that is how we then also make use of local people in communities and households to strengthen service delivery within those areas. They are led by a professional nurse. So these teams are linked to a primary healthcare facility. They meet weekly with a professional nurse who is also the facility manager. They discuss issues. If there was for example, a mother who gave birth and she didn't turn up for the 6-week postnatal checkup, it gets discussed there. The facility gets informed. The community health nurse then says, okay, one of these community health workers need to go out there, do a follow-up, do a checkup why the person didn't pitch. Issues like chronic medication, it gets registered, it gets fed through to the facility knows this person is on this kind of medication. And also, if it's somebody coming new into the area, the person also gets notified by SMS to say, this is the nearest facility, you should get your chronic medication, for example.
Exactly. So I want us to come to you just to get perspective on these innovations that are taking place, not only in the public sector, but also in the private sector. Are your doctors and the people that you have on the ground actually making use of these facilities, because that's why they're there? And more importantly, following their experience in these rural environments, what kind of level of participation do they have with private sector players and state players to maybe alter the level of innovation to a different level where we find more innovative solutions to deal with the current crisis that we have on the ground in healthcare?
So we place, the health workers we place are almost entirely in rural areas. And that's our focus. We focus on facilities that either don't have a health worker or have too few health workers. And depending on which services are available in which facility will depend on which technologies or innovations they have access to there. The one thing I can say, though, that a doctor in a hospital is, I think, a little bit misunderstood. The first way in which they're misunderstood is that a doctor in a hospital is actually a highly specialized skill. And people think that GPs working in a rural hospital is a generalist skill and need to go to a secondary or tertiary facility to actually get in touch with a specialist skill. That's not the case. Doctors are highly specialized. In actual fact, where healthcare is really tackled at the most primary level is in communities, through community health worker programs like what Bennett was talking about, through mobile technology which reaches into the households, into the community. And only when you get into the community do you understand really what the health issues are. And if you can get into the community, and these technologies can reach more into community, but if people can reach into the community, if community health workers can go there, maybe facilitated by technology, better and better, then we'll be able to tackle health issues before they become expensive and before they need the highly specialized and highly scarce resource of a doctor. The second misconception about a doctor is a doctor is a doctor. In a rural community, a doctor is not a doctor. A doctor is an advocate for the community. Our doctors living in rural areas will walk to the local shop and everyone there will know their name, and they will take that doctor to the front of the queue because that doctor is looking after them and their families and their community. That doctor understands what the health issues are surrounding that community and will start various programs, innovations that relate to healthcare or innovations that relate to the social determinants of health that they can see from their highly specialized, highly educated perspective that they bring into a community in a very unique way. They have a very unique perspective. And so those doctors and communities actually do more than just doctor work. And in that sense, yes, the doctors, when they're in our rural communities, get a very clear sense of what is happening, and there's nobody there with that sort of perspective, and so they are able to offer healthcare and other innovations into communities. And certainly when they leave those rural hospitals, we've heard from a lot of international and local doctors that their career choices have changed. They may not necessarily get involved in the innovation space, but certainly if you can imagine the problems that are going on in the US healthcare system at the moment, for example, that healthcare system, the custodian of that health system is doctors, are doctors. If every single one of those doctors had worked in a rural African hospital, do you think that the American healthcare system would be in the state it is at the moment? I highly doubt it. And so what we're also offering the international community is the opportunity to give their doctors perspective on what it really means to offer healthcare and what healthcare is outside of offering those highly specialized skills in a hospital or in a practice.
I want us to move forward and chart the way forward into what the future of healthcare in Africa looks like, with the role of the government, the private sector, technology, innovation, and the experience of international players who come and have their experience here on the continent. Michael, to start off with you, it seems as though the government has a lot of projects that might coincide with what the private sector is doing. Number one, your perspective on more collaborative efforts, especially from a public-private partnership perspective, and the landscape. Does it need more money, the resources, as well as upskilling the workers who will be on the floor?
I think for many years now, South Africa, in terms of our healthcare environment, has spent all our time pulling people out of the river and not going upstream and stopping them from jumping in the river in the first place. In other words, we've had a very curative approach to healthcare and less of a focus on prevention. And we know, all four of us know, that prevention is better than cure. Yeah. And we're finding that for the first time, and to be dramatic in the history of mankind, we have a technology, we have a device available that gives us access to individuals on the ground to educate, to access them directly with preventative messages, and relay information that assists them and educates them and takes the responsibility for their health and puts it into their hands. Because another thing that a doctor is not is responsible for your health. You are responsible for your health. A doctor is there to advise you on that, to assist you that when things go slightly wrong, but ultimately the responsibility lies with you, and what this technology allows us to do is to give that responsibility to individuals. And I think what the government is doing in terms of utilizing mobile technology, the apps that you guys are using, Mom Health, fantastic app, that Mom Connect, is wonderful. I think we should be doing more. I think the NHI is a 15-year project. We're a couple of years into that, but I think mobile technology allows us to leapfrog that, to get ahead, and to take the limited resources that we do have and to make the most of them, to maximize what we've got in an affordable and accessible way. And that's been the vision of Hello Doctor. I think that's the vision of the government as well, in terms of maximizing mobile technology.
Is that the vision for Philips, Jose? Because you've got several projects as well, the simulation centers that you've got at UJ, new innovations that you bring onto the market, such as Visic, if I'm not mistaken, that does ultrasounds in rural areas. Are we on the right track, and how do we progress going forward by leapfrogging several levels of innovation?
Well, you know, from a Philips perspective, we've just launched today our Cape to Cairo roadshow.
Yes.
And I think one of the objectives of this roadshow is really to engage and collaborate with multiple stakeholders, so customers, governments, NGOs, the media, private institutions. And it's really to talk around challenges around Africa. Why do I say this? Because I go back to collaboration. Actually, going forward, I think it's all about collaboration. That's what Philips does, or is trying to do a lot in a lot of the countries around Africa. You know, we see a lot of initiatives in Africa, South Africa, which are so-called vertical or silo solutions. So they either tackle AIDS, or they tackle TB, or they tackle cancer. But at a fundamental level, we seem to be missing that solid reinforcement of healthcare. And we believe that it's about collaboration. Not one supplier can do it, not one government can do it. And so, you know, if we look at projects we're running throughout, again, Kenya as an example, where we've just launched a community life center in Kiambu province. It's quite impressive what happens when you collaborate, because there we set up a rural clinic, we revitalized, we expanded, but we went quite far. We got partners at Bolt, we went into incineration, we went into clean water, we went to off-the-grid electricity, we staffed, we trained, and it was a complete holistic solution with a clear vision, with multiple stakeholder partners on board, and the results you get are phenomenal. So all of a sudden, just to give you an example, where this clinic originally, a small little clinic, was seeing, I think it was 300 people a month, within 3 months they were at 4,100. And where there were 60 antenatal visits, all of a sudden we were at 400. There were virtually no live births at the clinic. Then I think we were at 25 after 3 months. So I think to Philips, collaboration is really a key word. And you will see that multinationals have a stronger and stronger role to play in strategy, global strategies around healthcare. But no one supplier or party can do it on their own. So it's really about collaboration.
So to bring your voice to the conversation, more collaborative efforts, whilst the international skills base does come onto the continent, but we need to find something that will make this more sustainable. Maybe those doctors upskilling the patients that they treat and making them doctors later on to come back and serve their communities. But from your perspective, where are we lacking, and what can we do to strengthen this path to accessibility to healthcare on the continent?
Where there's no healthcare worker, there's no healthcare delivery. So if you want to strengthen access to healthcare, you need to start with the people. Certainly the ways in which technology can leverage people to allow them to reach more people, more patients at least, but you need the health workers. And in that sense, what you've got to do is one of two things. Either you've got to train more of the same in an existing system, or you've got to look at maybe the system, changing the system. And the reality is that we will never be able to train enough doctors and enough nurses to treat everyone on the continent. It's just, we just don't have the resources to do it. But we do have an understanding now, different to the times when doctors and nurses were the method of delivering healthcare in Europe and America, for example. We do have the understanding now that we need to reach into communities. And so in my perspective, if you really want to create some kind of integrated healthcare system, you've got to tackle things as early as possible. And the collaboration and the coordination needs to happen at closer and closer to community level. It will be much more cost effective, both in terms of preventing before you need the highly and costly specialized skills of a doctor or even a nurse. And you can get those entry-level positions to do community health worker work. It allows the use of technology, which isn't every household already, and it allows you to tackle all things simultaneously, not in vertical programs, as Jose mentioned earlier.
Bennett, to come to you for closing comments. The government does get a lot of the slack, but today we have heard about the progress that you've made and the support that you're also getting from the private sector. From your perspective, what more do we need to do to get to where we want to be?
Well, I think we need to bring down the cost of delivering healthcare. It is, our input cost does not justify our health outcomes if we want to strike a balance with those. Secondly, I think we need to work closer with partners and make them understand what it is that we're trying to achieve. The first thing a service provider will give you when we have a discussion about something is a quote. It will cost you so much, all right? And I think we need to change that notion also. Yes, business is there to make business, all right? But we need to drive home this notion of corporate responsibility, community responsibility, make more investments back into the communities, okay? I'm not saying a company should bankrupt itself because now all of a sudden everybody must deal in its profits, etc. But I'm saying within the context of providing healthcare, we need to drive down the costs. We need to make sure that technology becomes much cheaper than what currently the situation is. And thirdly, I think bringing those technologies into play in providing healthcare will make sure that we can actually design and deliver more on bringing in more apps, because there's a multiplicity of these things out there, and everybody claims for that particular product to be the best. It's not necessarily the case. Okay, so yes, competition is healthy, but in this case, I think competition is unhealthy because we're trying to solve the same problem here. Thank you.
Michael and Jose, it almost seems as though you have a tough job ahead of you, but more collaborative efforts are clearly what we're looking for. And on that note, that's how we wrap up this day's edition of the African Philips Dialogues: innovation, collaboration, investment in supportive structures, and more importantly, the people who are doing the work itself, the healthcare workers. We also need to prioritize them in delivering the service to the masses of people on the continent. Well, that's where we leave it for today. Thank you so much to my panelists for joining our conversation. Jose Fernandez, General Manager of Philips Southern Africa for Healthcare; Bennett Asia, Director for Districts and Development at the National Department of Health; Saul Cornick, the Chief Executive of Africa Health Placements; and Dr. Michael Moore, founding member of the multinational company. Hello, Doctor. Not forgetting our audience members for sitting in and listening to the insights being shared by our panelists, and Nick Henry joining us from the RISA Project Development. Well, that's where we leave it today. Coming to you from Diepsloot, where the mobile clinic by Philips in collaboration with RISA has officially been launched. I'm Kukulethu Cele for CNBC Africa. Until next time.